My name is Philip Lodge. I'm a consultant in palliative medicine and I came to the specialty via general practice. I'm here today, hopefully, to give you some useful tips, particularly about end-of-life care and the recent NICE Guidelines. I think the recent NICE Guidelines are more aimed at structure, resources and the organisation of service for people with palliative and supportive end-of-life care needs. I think as individuals working within the system, the guidance is useful, however, it will not be directive as such. I think it's helpful because it will focus us on what our local services are currently and how we can use them to support people in each setting, hospital, hospice, community. End-of-life care may be defined as perhaps care in the last 12 months of life. However, clearly patients will be having supportive disease management during that time, such as chemotherapy, and therefore for some patients perhaps end-of-life care is a shorter time. I think palliative care is throughout the whole course of someone's condition. Supportive care might be defined as the care that we give alongside that active management of a disease. So our practice, I think, spans 4 different arenas. The hospice inpatient population, which majority of patients will be referred in for symptom control, then end-of-life care, and a smaller number for rehabilitation or respite care. I think the hospice inpatient population is different to my hospital inpatient population. Paradoxically, I think the hospital patients are sicker and more likely to have come in with complications of treatment, toxicities and so on, or actually because they're dying and they come in as emergencies. And then there's the hospice outpatient population, the walking wounded, who have long-term conditions, not necessarily imminently life-threatening, but who need ongoing symptom control and perhaps therapies alongside that, such as physio, occupational therapy, complementary therapies. And then there's the community setting, where we are trying to maintain people as long as possible and as well as possible at home, looking at their physical symptom control needs, plus things like equipment, provision of care, and sometimes things like financial advice, actually, benefits and so on. One of the major challenges that we are dealing with is the fact that the majority of our workload, both in general practice and in the hospital setting, is patients with long-term conditions. For general practice, this is a major issue in terms of time needed. I do not expect that a general practitioner can spend half an hour with an elderly frail patient in the middle of their routine surgery. Prognostication is clearly something that we are notoriously inaccurate at. And I speak as a palliative care clinician and I should be good at it. I get it wrong. I do, however, think that there might be triggers for us to think this patient may well be approaching end of life. Particularly in general practice, that may well be a diagnosis. It could be admission into a nursing home. The UK nursing home population has a yearly mortality of about 50 to 60%. Therefore, it would seem very reasonable to have a discussion at that stage. It may be recurrent admissions. We know that, generally speaking, acute admissions of all cause in this country, about 30% will be dead in a year. And if they're over 85, probably 45% plus. So this is significant. I think having either an end-of-life care register, a palliative care register, regular meetings with the local palliative care team will be helpful. It is very important to recognise when people may be approaching the end of their lives, because it allows, hopefully, us to raise really important issues with them and to help them, hopefully, plan. It's better for the family as a whole when these conversations are open. Everybody knows what each other is feeling. When it does come to the point, as it may well do, where that person can no longer speak for themselves, the members of the family will then feel more able to speak on their behalf and help us to make the right decisions about their care. I think it would be preferable to have a more formal and systematic way of identifying people who may be approaching the end of life. I think this is another challenge. However, it could be that a diagnosis alone is enough to trigger the conversation. For instance, COPD with an emergency admission, or heart failure with an emergency admission. We know that those patients are going to be at higher risk of death. I think some of the Cinderella conditions needs to be considered. I think particularly dementia, and it is an enormous problem, often coexisting with other chronic diseases, but dementia is a terminal disease, and if we do not address that early in its path, we lose the opportunity to speak to the person themselves about how they would wish to be cared for. Provision of information for people with any kind of cognitive impairment, learning disability is a challenge, has to be individualised within the context of what they are able to manage. I think where people have been assessed as not having, for instance, capacity to make decisions regarding their care, it does not mean we should not include them in discussions. I think it's yet another challenge that this guidance outlines, and the time needed sometimes to have these conversations with someone whose understanding is difficult is clearly going to be great. So again, this needs to be shared. Often people will have either professional or family members who are caring for them, who will know them well and can actually have those discussions, perhaps even better than we can. So use the expertise around them. When someone's recognised as approaching end of life, the NICE Guidelines refer to a review of their current treatment, and I think in particular for general practice this relates often to medication and their repeat prescriptions. I think if you recognise someone is approaching end of life, it's a very good trigger to review their medication, and I would suggest that often there will be medications that are aimed probably at long-term conditions to try and prevent either progression or symptoms that may arise in 10 to 15 years' time. Some good examples are statins. Why are we treating someone with a prognosis of almost certainly less than 12 months with a statin to prevent a stroke in 10 years' time? Add Cal D3, vitamin D and calcium supplementation. We're all vitamin D deficient probably. Do we really need to be treating patients who are elderly, frail, with a short prognosis to try and stop them getting osteoporosis or worsening osteoporosis? I don't think so. There will be other examples. I think there are some tricky decisions sometimes, particularly with diabetes, for instance, where patients are very, very familiar with their condition, monitoring their own blood sugars, and they will be probably quite anxious at the idea of either stopping or reducing doses of oral hypoglycemics and certainly insulin therapy. The NICE Guidelines place a significant emphasis on advanced care planning. Advanced care planning is a process, a series of discussions, hopefully with the person themselves. If they've lost capacity, it may be that conversation will be had with their family, next of kin. It is to try and establish their views and wishes on how they are looked after in the future, and will consider, hopefully, things that might be predicted to occur, such as what would happen if I were to develop a pneumonia on the background of my Parkinson's disease. Would I wish to be treated in hospital with intravenous antibiotics and so on? Or actually, is it my wish not to go to hospital anymore and to be kept comfortable at home or perhaps in the local hospice? it may not be as stark as that. And I think there is, again, a journey to be had in terms of what is discussed and when. Patients' conditions will progress, and therefore there will be a need to review their current treatment and plans around their care. It is hard to put in a systematic way of doing this. It may well be opportunistic. The patient will hopefully be contacting the practice or the district nursing team or the palliative care team should things change. For many patients, they will be under regular review by default, either in the practice itself or, as I said, with the community nursing service. When something crops up, it's advisable then to use that as a trigger to review the whole circumstance. As GPs, I believe you will be very much familiar with multi-professional team working and using all the community services that are necessary to maintain patients at home. And palliative care is no different. Clearly there will be, hopefully, the local community palliative care team, which may or may not include community physiotherapy, occupational therapy and social work. For particularly complex patients, perhaps a good example would be someone declining at home with motor neurone disease, who may need, beyond perhaps the palliative care team and district nurse support, the respiratory team to monitor non-invasive ventilatory support at home. So I think tailor it to the individual. Coordination of end-of-life and palliative care is key to making sure that the services we deliver are relevant and effective. Who leads on the coordination, I think, needs to be determined locally. There might be, for instance, a Macmillan GP facilitator, there might be a community matron, there might be a frailty hub, all of which may take the coordination role. I have experience of a local change whereby we put in place a rapid discharge from hospital pathway for people who had days to live and wished to die at home. And this entailed working together with the transport service, the pharmacy and continuing healthcare in the community and local community nursing services, district nurses, plus the community palliative care teams. And it has allowed us to be able to do same-day discharges with provision of equipment such as a hospital bed, commode and so on. And although it's time-consuming, it has made a significant difference to patient and carer experience and has certainly allowed some people to be in the place of their choosing. Out-of-hours care for patients who are dying at home is key to maintaining their wish. I think where there is a nighttime district nursing service, hopefully problems can be anticipated and dealt with. For instance, providing injectable anticipatory symptom control medication may well allow patients to stay at home when, in its absence, almost certainly that they would have to go into A&E. As much as you can, put in place that anticipatory plan and make sure at least the medication is provided with the right administration charts so that any district nurse, palliative care team, clinician or even paramedic can administer that really helpful symptom control medication. The NICE committee also recommends that there is access to a healthcare professional who can see that particular patient's records and advanced care plan and make decisions, that there is a pharmacy that can provide out-of-hours medication, and that there is also recourse to a palliative care advice line. These guidelines are aimed at helping us to optimise the care of patients with palliative and end-of-life care needs and to smooth out those variations across the country. I hope you have found this film helpful. Thank you for watching.